Hello and welcome to lesson 4. What we're going to cover in this one will be all about leg length discrepancy, and I'll also discuss overpronation and the effect on the gluteal muscles. So let's move on. So you might want to have gone through this already. So you might have printed it out or just read it. So now you're ready for me to discuss part of some of the images. Now, a little complex subject. So I will try, if it's possible, to simplify some of the testing and the compensations as we go through. So when we think about it, I'm going to use a little red pen here. Now, definition, so we've got a leg length discrepancy, okay, so it's called an LLD. So naturally there's potentially many causes of. So imagine you are seeing a patient, and then one of the first things I do is to look at the position of the pelvis. It does not matter if they present with, say, shoulder pain, neck pain, knee pain, foot pain. I tend to look at the pelvis to see if they are level. And if they are not, then maybe they have a leg length discrepancy. They might not, okay? So one of the common ways of measuring, even though it's not an accurate measurement, they've done many studies. So if they had, say, 100 therapists and they asked them all to measure one patient from the typical place of the medial malleolus to the anterior superior iliac spine here, then it looks like it's a simple measurement, okay? But between 100 therapists, they might say, some might say it's 90 centimeters, some might say it's 89, some might say it's 91, and so on. So the reliability between therapists is quite low. So just bear that in mind here. Now, imagine you take the measurement from one point to another point and you say it's, let's say it's 90, and then you measure the right leg and then you say it's 90, then more than likely the leg is of equal length. You might also have looked at the malleolus, okay, the two malleolus here, to see if they are level along here as well. You can also look at the umbilicus, okay, so you can take a measurement from the umbilicus to the ASIS and then take that measurement from the opposite side to see if there's any maybe rotation within the pelvis. So if we measure for an apparent leg length, so let's say for instance this is level here, but then when we go on to taking the next measurement, we are measuring from the medial malleolus to the umbilici here, you might find you test the left and it's say 95, and then you test the right along here and it might be say 94, excuse my squiggly liner, but you know what I mean. Okay, so you might find it's 94. So that shows a 1 centimeter deficit. But when you went back and took the measurement for the true leg length, it was equal. So they might have an apparent leg length discrepancy. They might have, for instance, if that leg appears longer, then the ASIS might actually appear to be inferior. So there might be an anterior rotation on this side, whereas this innominate is going posterior. Okay, so it's going that way. So maybe that's why the leg looks shorter on that side, and then the other side is anterior. That's maybe why the leg appears to be longer. Many reasons why. You can see some structural reasons why we've got a true leg length discrepancy. We can have a functional, idiopathic, and so on. And you can have a read of this in your own time. So have a look at this picture here, okay? So we've got a higher left crest compared to the lower right crest. So you can see that there's an obvious difference between the left side and the right side. So it might be that the femur is anatomically longer, you might have fractured it, or maybe the tibia and the fibula along here might be anatomically longer. Or on this side, most people talk about the long leg, but not many people mention the short leg. So if you have a shorter femur or shorter tibia and fibula, then that might be a reason why you have a lower right side in here. And if I'm honest, if you can see the spine is going to, can you see there's already a curvature forming as a result of this position here. So we can develop a scoliosis. If I'm honest, one of the simplest ways of correcting this, if it is a true anatomical leg length discrepancy, then is to put a lift under the shoe. You might agree or disagree. And let's say you've measured it to be, say, 6 mils, then you might put a 3 mil wedge under the shoe, if you like. It's called a heel lift, and then see how the patient progresses over the next week or two to see if the symptoms subside. And that would be one of the simplest ways, yeah, to start with. But be careful, because you don't want to use the same height. So if they are 6 mil, let's say with 10 mil, 1 centimeter, we do not put in a 1 centimeter because the body compensates very well, yeah, for a few millimeters. So we tend to roughly go to half, is what you believe. Okay, let's move on. Now, as a result of, it does not matter if it's a true leg length discrepancy or whether it's an apparent leg length because you've got a rotational malalignment, you might find the foot, this is the neutral position for the foot, but you might find the foot compensates at the subtalar joint in here. Okay, so this is the talar-crural joint in here, and then you've got the subtalar joint in here, okay? Yeah, not the best picture, but it's okay. Yeah, around that, so it's under the talar set. So it's called the STJ pronation. And typically, we normally pronate around 5 to 6 degrees, that's normal. And it's true and same for every degree of pronation. So when you think about pronation, it's a combination of dorsiflexion of the ankle and abduction eversion of the foot. But when you do pronate, it will take the tibia with it. So for every degree of pronation, let's say you have 1 degree of pronation, then you'll have 1 degree of subtalar joint motion, which then takes the tibia with it. So when the STJ pronates, then you'll have increased tibial rotation, which then has a knock-on effect towards the connective chain. So the tibia, the femur, yeah, the hip, and then the innominate will more likely rotate anteriorly on that side. If you've got a true leg length discrepancy, let's say for instance the left leg is physically longer anatomically, then it has a different type of compensation to the pelvis. Okay, it has a different type. Now, let's move on and I'll show you what I mean. If we have a longer leg, true leg, then you can see here, so we have a long leg compensation. So what it's trying to do is we have a long leg, but it's trying to compensate. And how it does this, which is not normal by the way, okay, it rotates the innominate posteriorly to try to shorten itself. Whereas on the shorter leg side, it tries to anteriorize itself to make it look longer. Okay, so let me just explain again. So with a long leg, true long leg, it tries to make itself look shorter by posteriorizing the left innominate, and on the short leg side, it tries to anteriorize the innominate, which is not normal. Okay, this is not normal either, because typically, if we have this is the sacrum here, okay? You can see this is the left oblique axis, and it's trying to show that it's rotating to the left here. Not the best arrow, but it's okay. So it's rotating to the left on the left axis. Normally, when the sacrum rotates left, the innominate goes forward. And then when the sacrum is going forward on this side here, so this bit's going into nutation, then this bit will typically come back, okay? However, with a true long leg, it almost forces, so as this comes back, it almost takes the sacrum with it. All right, it's a bit more complex with a lumbar spine, but it tends to rotate, the sacrum tends to rotate to the long leg. Okay, so just bear that in mind, and side bends towards the short leg. So it's non-physiological motion, this. So be careful when you read other stuff on sacral torsions because it's the opposite. Let's move on to this. So you can see here that we've got a high, low side. So the lumbar is going to side bend towards the long leg, and then it typically rotates towards the short leg. Okay, whereas the sacrum tends to rotate towards the long leg, and then side, let me just change it, and then side bends towards the short leg. So it's called a type 1 mechanics. Remember I was saying, so this tends to go back, yeah, this tends to go back here, and then this tends to go forward as the compensation. Also further down, if you've got a long leg, it tries to bend its knee to shorten, and also on the leg, it tries to pronate as well. Why? Because it's trying to shorten itself. And on the short leg side, it tries to hyperextend the knee here, and then it tries to supinate the foot. So that's what we tend to have on that side. No doubt there are alternative compensations for that, and it has a knock-on effect. The thoracolumbar junction point here is involved. Okay, the AO, well I call it the OA joint, the occipital atlanto or the atlanto-occipital, doesn't matter. The CT, cervical thoracic or cervical dorsal junction. Yeah, so it all compensates up. So even though the problem, say, could be the femur here, okay, is a little shorter, look at all the compensations in the red. It just goes on. So you could present with left shoulder pain, yeah, cervical spine pain, mid back pain, lower back pain, knee pain, foot pain. It just goes on, okay, as a change because of a functional scoliosis. The problem is with functional scoliosis, it very soon becomes a structural scoliosis, and then it's a tricky one to correct then. Let's move on. We have some compensations. I mentioned it already. Okay, we talked about the psoas in here. You can read that in your own time. So you might have some tightness, yeah, with the hip flexors. I said earlier, yeah, the sacrum tends to typically rotate towards the long leg and then side bend towards the short leg. So we tend to have that. So if the left leg is longer, then we'll have a left on left sacral torsion. And if the right leg is longer, you'll have a right on right, which is not normal. Okay, so just bear that in mind. Yeah, around in here. So you can have a read of some of that. Moving on. This is what I'm saying about the pronation. You can have a pronation on the true long leg. Why? Because it tries to shorten itself. But typically the pronation will occur with internal tibial rotation here, along here, which then tends to be, the innominate on its side tends to be anterior. So if you look at the foot and the pelvis, it might be lower, it might well be, but it's an anterior rotation of the innominate. However, if it's a high side on the pelvis and you have a pronation on the foot, then you might find that it is a true long leg. As I said, it's a little difficult to understand all this sometimes, but I'm hoping that me explaining it as I go through the lesson makes a little bit more sense to you. We have some compensations to the glutes here, okay, so leg length discrepancy in the glutes. Now, this could be, if you're looking at this, okay, so a pelvis that's high, and it could obviously be a long leg, but when you measure the long leg, it is equal, okay, it is equal. You might notice some changes to the foot position in here, but you might find that if the glute is weak on that left side, the adductors and the QL, which are postural muscles, shorten. So the glute is weak, so we have that shift over, so like a lateral shift. Yeah, and then it compensates. So it looks high, okay, so it looks high, but there's no leg length discrepancy. It's due to the musculature, like the glute being weak. And then you might find, if you ask the patient to stand on one leg, called the standing balance test, you might notice the pelvis dips down, but it's the right side, in this case, glute, that would be weak, allowing the pelvis to dip, and it ends up with a Trendelenburg gait, yeah, along here. So this would be the left leg. So when you test the left leg glute, it would be weak, so the pelvis would dip on the right. However, on the right side, the glute med is relatively strong because of the change of the pelvic position. Because when you think about it, okay, this leg is more in adduction, okay, hence why the leg is adducted and the adductors become tight because of this shift. Whereas on this leg, it's more in abduction, okay, so it's more in abduction here. So you might find that the glute medius is shortened and tight, and then the adductors are now lengthened, and the same with the quadratus. So don't automatically expect what you see on the left side is replicated on the right side, yeah, as a result of that. And again, you can read about that in your own time. This is what I mentioned just now. So the Trendelenburg, can you see? So this left glute would be weak, and the pelvis is dipping down to the right side here. So when she steps on the leg, you can see there's a side bending to the left. Okay, and you can see that you could end up with back pain, easily back pain in here, the facet joints, yeah, where they're compressing together. Even back pain on the right side, where the joint capsules are being stretched in here. Okay, no doubt the position of the pelvis, the SI joint is compensating, so you could get pain along the sort of like central sort of sacral area. You could get pain on the left SI and the right SI. Yeah, maybe the knee, yeah, because you might find you have a medial knee drift on this side, okay, so it rotates inwards on this side. This is the compensatory one, so because this uses effort and energy, so when you step on the left leg, the body compensates. So this is a compensatory Trendelenburg, so now it ends up hitching, so you end up hitching up here, okay, so it ends up lifting. So this is a compensatory Trendelenburg gait. Either way, when a patient is walk-in, you can have some form of antalgic gait, and it's up to you as the therapist to try to work out where it might be coming from. I hope you understood part of that lesson. You might want to listen to it another couple of times before you go through your assessment and to move on to the next lesson. If you have any questions, then you can leave them in the comments box. Thank you.